liquid biopsy is not something new. It has been done in other cancers, in colon cancer, in prostate cancer, in melanoma, lung cancers. There has been studies specifically focusing on the findings in the blood for surveying for the cancer. This majority of the studies that have been done in the past has been focusing on the exosomes, including the RNAs and DNAs, specifically, for example, ctDNA, cell-free DNAs. But not a lot has been done on the rare cell events and basically, specifically, large extracellular vesicles, which are other components that might be available in the blood and have correlations with the tumors. In urothelial cancer specifically, there has been studies on ctDNA, and as we know, there is actually clinical indication for using the ctDNAs nowadays, specifically in the patients with invasive disease undergoing cystectomy. Having said that, on other components that I mentioned, there has not been a lot of studies. In upper tract urothelial carcinoma, there has been some small studies on ctDNA as well, but specifically looking at the circulating tumor cells and the rare cell events, as I mentioned, there has not been a lot of studies, and that has been the focus of our study that got published in Urologic Oncology. I should mention that by no means I'm a basic scientist, and obviously I'm probably other people can explain this better than me, but as a part of the team, which we had a great collaboration, we have a great collaboration with our basic scientist teams at Michelson Cancer Institute here at USC. We looked at rare cell events specifically in the blood for surveying for upper tract urothelial carcinoma. Well, why we did that? Well, we had the technology available, the HDSCA, which is high definition single cell assay or analysis, is a very novel technology that we are fortunate that we have experts on evaluating and working with this technology. And they have done a lot of studies in other cancers with this, essentially looking at any cell that might be available in the blood, and not just necessarily looking at the mutation burdens through the ctDNAs and so on and so forth. They have looked at breast cancer, and they have done studies in melanoma, lung, colorectal, and upper tract, as well as bladder. They've done the studies as well, but upper tract was basically the next step in terms of exploring, as there has not been a lot of studies in that field. Through this study, we specifically looked at 8 cellular level circulating tumor cells, as well as the 4 large extracellular vesicles. A lot of these LEVs are essentially probably released by those circulating tumor cells in the blood, whether through the infiltrating through it or shedding or breaking, or maybe de novo. We're not 100% sure. But these 8 cells and 4 LEVs were mostly essentially highlighted through their biomarkers. And the immunofluorescence assay was done to detect like the cytokeratin at that level, or vimentin, or other like CDs and things like that. Computationally, they were assayed and manually were specifically counted to make sure we're not missing anything at the first steps of these studies. And the highlights was that we looked at the recent data we have on 28 patients with upper tract urothelial carcinoma. We looked at pre-nephrourectomy or distal uretrectomy for this invasive disease in compared to that basically to post-operatively, we saw that there is a significant correlation in terms of pre-post evaluations in these numbers, the total cell counts and the total events, as well as specifically for each of those circulating tumor cells, as well as the oncosomes. This was pretty exciting when you see that both epithelial and mesenchymal components, you see a drop after surgery. So clearly tells us that by removing the primary tumors, you see the difference in the blood level. By no means, this is a sort of a very high level of study that is getting something out directly to clinical practice. This is more of a pilot, this is more of exploratory, this is more of a discovery. I will call it to better understand exactly what's happening beyond the some of the markers in the plasma that have already been measured. ctDNA, which essentially measures the mutations in the primary tumors that excreted to the blood, have been measured. But I think there are some other components. There are some other stuff that's happening in the blood in these patients, and the rare cell events is one of them. We understood that some of these markers, as we talk, there is a difference pre and post surgery, and there's a decline. We also noticed that some of these markers do have some correlations with the oncologic outcome in terms of recurrence. The sample size that we looked and we had the outcome for this specifically is small, I would say. And the median follow-up has been only 11 months per this report. Obviously, we're continuing to follow up these patients. But I think, and we see some changes. We see some of those cell types, as you mentioned, preoperatively, there is correlation with recurrence, free survival, as well as both in the cells as well as the oncosomes. We have seen some essentially insights, but I think this is still exploratory, and we're not 100% sure on the meaning of it down the road. Needs obviously a larger sample size and validation. One of the components that we also have looked at is the changes that happens and the correlation, the changes that happens in these biomarkers, as well as the correlation with the clinical parameters. Some of them are clinical pathological parameters from the tumors itself, of course, demographics, but also the outcomes as another variable next to these biomarkers. I think at the end of the day, when we look at all these markers in the blood, including ctDNA, including these rare cell events, I think they're all complementary to each other. And then I'm thinking of sort of a panel at the end of the day that has, all these markers that prove to be associated with some outcomes of interest, oncologic outcomes, to be included in this panel. And then we come up with sort of a very hopefully a high AUC, area under curve, for this panel to maybe help us with diagnosis before surgery, maybe help us with a prognosis even before or after surgery, maybe help us guide what sort of a systemic therapy the patients should get. And at the end of the day, prognosis and prediction of recurrence, also this panel potentially can help with.